Thank you for coming to the talk on Dynamic Digital Radiography. Just as I've just introduced myself, my name is Florence Doo, I go by Flo. I'm a second-year resident at Mount Sinai West's Radiology Residency Program. Again, I'm a second-year resident, okay? So I know enough to kind of go over this subject, but please, hopefully you stay entertained and that you get a good understanding of this new modality that Konica Minolta has installed in our institution. All right, so special thanks also to my mentors, Dr. Samaru, Dr. Concepcion, Dr. Gupta, Dr. Zink, and Dr. Kagan. All right, so to start, we're going to go over kind of this kind of organization of slides. So first, we're going to go over what DDR is, the current applications of DDR, and future applications of DDR. All right, so let's get started with what is dynamic digital radiography. Has anyone been to a prior talk on DDR before and kind of great? We have one in the audience. And for everyone else, let's get started on what it is. So what is dynamic digital radiography? And first we need to revisit what a static chest radiograph is. So dynamic digital radiography is really two components. It's the digital radiograph part, the DR part, and also the dynamic aspect, so that's in a different color. You get functional and anatomic information in a first-line test. What do I mean by that? So first, just going over what digital radiography is, which gives you anatomic information just like your normal static radiograph. So the technology that makes dynamic digital radiography possible is the flat panel detector. So you have people in the audience who might remember screen film radiography, where you had actual films kind of from the beginning of radiology and onwards. But recently, in the modern times, we've been using digital aspects of radiography. So that includes computed radiography and digital radiography. And you can kind of think of this in terms of analog versus digital. So the analog aspect is really taking X-ray radiation and applying that to a cassette that contains film inside of it. And you either have instant emission of light and exposure of the film, which requires you to develop it, and then you use a light box to view it, so that's analog ancient times. And then you have more modern aspects where you take a cassette that has a storage phosphor screen inside of it. You still need to take that latent image and externally read that out with a laser to convert that into a digitized system, so it goes to your PACS system, right, to read that on your computer screen. Well, you also now have, so that's kind of a bridge between the analog and the fully digital, because you have that cassette, that analog aspect where you need to take it somewhere else, and then you digitize it. There's fully digital aspects now with flat panel active detectors. And that really means you have a thick structured scintillator layer, which has good absorption for that X-ray radiation. But that light, right, that is then seen by the light sensor, the photodiode, goes to a transistor switch, and that is directly translated to electricity. So that kind of that's why you call that direct digital radiography. You have an instant kind of conversion of X-ray radiation to the digital signal that can then be transmitted over to your PACS system. So that's the first piece of, I guess, technology that made this possible. And the other important aspect of making that completely digital transition is that you can do post-processing. And there's actually a great talk that I went to on Saturday that was also co-sponsored by the physics group. I'm not sure if anybody in this room was there, where they talked about the ways that you could enhance radiographs now in the modern times, doing demasking, doing all sorts of filters that you could apply to it to enhance the image so that you can apply less radiation to the patient. Not only are you using a thick layer for good absorption, you're also getting the ability to take that digital image and kind of not Photoshop it, but enhance the image in a way that you don't need to apply as much radiation. So you have a low dose radiograph that has much better spatial resolution. So that's technology piece number one. And I just wanted to emphasize there's an article by Schaefer Prokop. I'm borrowing a figure from them. They have a table where they went over and compared all sorts of articles comparing screen film radiography and computer radiography and digital radiography to look at if that really did save any radiation. And one of their points is it does save about 30 to 50% of radiation dose, which is huge. And you then also to think about the ALARA principle, which they also mentioned in their paper. And I'm sure, as a lot of radiologists in this room know, you want to have the lowest possible radiation dose in order to make an accurate diagnosis. But then, now that you have this ability to have a low dose radiation X-ray, what capability can you think of research-wise, or even for your patients, right, that could give you better diagnoses, different diagnoses, and ways to bring benefits to your patients? So that's where we bring in that next piece of the functional information, the dynamic part of the digital radiograph. So again, we're looking at substantial change in management where we can add value to referring clinicians. So rethinking thoracic disease and breathing, I think just as a paradigm shift for me was really thinking, we see a lot of 2D images. There's a lot of machine learning and things to try to enhance the ways we see two-dimensional images, right? Pick out disease, pick out pathologies, and find those subtle variations that can lead you down the pathway of diagnosis. But really, breathing is not a static, it's not a static process. And breathing, I think, once you're not able to breathe, it suddenly becomes very important for you, how your lungs are moving. And I think that's how pulmonologists and the pulmonology colleagues that I've spoken with think about thoracic disease. There's a lot that goes into your breathing. I'm sure it's very logical once we go through the whole intern pathway of what impacts your breathing. Is it your diaphragm? Is it your neuromuscular areas? Is it perhaps something more GI-GU? There's a lot of different areas, right, that are impacted by that. So if you have something that's low dose, right, that you can take an image, what about taking sequential images, kind of like in a fluoroscopic way, but then being able to quantify that, right? If you're able to measure movements in your lungs, perhaps with that post-processing step, and give your tech a protocol to do that inspiratory phase, the breath holding, the expiratory phase, watching how someone normally breathes, that could tell you a lot about their pathology and their disease. So again, this is part of that process, that post-processing that I alluded to earlier, where you can take that dynamic digital radiograph, you can do a lot of post-processing on the radiograph to enhance those structures and emphasize the structures that you're interested in. I'm sure if you've seen subtraction radiographs, you might have a way of visualizing that in your head. And you can also then take the second part of that image there, you can do tracking, you can do specific components for the diaphragms. You can then measure the diameters and the distances between different structures and quantify disease in a very different way. This is very exciting because this is a radiograph, which is pretty much a first-line tool that we use in a lot of medical diagnoses. So here is just a diagram to show those capabilities. All right. So here we go. This is an example of a dynamic digital radiograph. So here on the left side, you can see the normal breathing of a patient, and you're not fluoroing this patient nonstop. You're doing sequential imaging, very timed well. You can see on the right-hand side the graph of their diaphragmatic movement. So the blue line is their right hemidiaphragm, and the green line is their left hemidiaphragm. All right. So now that we have an idea, a general outline of what dynamic digital radiography is, again, it's that functional information along with the anatomic information, perhaps combined as a first-line test. Let's now think about those applications. Okay, so again, this is the overview. We're going now into the second stage. So now current applications. How does dynamic digital radiography fit, and when would you order this, or when would your colleagues order it? So let's think about that as a first-line test. This is a general sketch of the tools that are available to us as radiologists and also to non-radiologists diagnosing thoracic disease. So you have your X-ray, your fluoro, which is generally used for sniff testing, and not the way that we're describing it, CT, nuclear medicine exams, and then on the non-radiology side, you have pulmonary function tests and echocardiograms. So to correctly diagnose thoracic disease in the emergency room or the outpatient setting, there's a lot of potential steps and avenues you could go down depending on what you think the diagnosis will be. So, and not all of these obviously can be done portably or in the emergency room, but just to re-highlight the types of information we're able to get. They're very separate. You get an X-ray, you get some basic 2D anatomical information that maybe people can act on, whether that be placement of a line or pneumothorax. The fluoro exam is very functionally based. You really just do the sniff test to get to see the movement of your diaphragms. CT is kind of a 3D multi-axial multi-axial, multi-sectional way of visualizing the anatomy. That's very expensive. That's a second-line test usually. Nuclear medicine is very specific for pulmonary embolism, and you can use it in other ways. And pulmonary function testing separately, just to think about that, I'll go over this a little more later, but it gives you a global pulmonary function picture. And I want to emphasize that because that's important later. Global pulmonary function means you're breathing, you're doing a test such that it gives you a function, a number, but just for all of your lungs at once. I'll explain why that's important later. An echocardiogram to give you cardiac function, right? Your ejection fraction when you're going to the emergency room, maybe there's some heart failure. As a clinician, it's important for you to know whether or not that person going through heart failure has an ejection fraction of 20% or 60%, and it changes the way you will treat that patient. So we're specifically going to narrow down at this point in the talk on x-rays and pulmonary function tests. This was an area that was identified by the pulmonologists at Mount Sinai West and St. Luke's as an important area for them to understand thoracic disease. So let's talk about that now. So with static chest radiographs, again, this is 40% of all imaging tests worldwide. And we're not really going to talk about, I crossed out the fluoroscopy and chest tomosynthesis. I know they're available, but we're not going to talk about that. So here is the first thing to look at. This is a chest radiograph. In theory, it's a static one. I know you can see the line, so you have a hunch that it's going to be a dynamic one shortly. But I'm not going to torture anyone by making them read it. But generally speaking, your chest X-ray report would look like this. The history is a former smoker in the emergency room with acute shortness of breath and COPD. Your technique is PA left lateral. Your findings looks pretty normal. The cardiomediastinal silhouette is within normal limits. The lungs are relatively clear, maybe some increased parenchymal markings, but there's no vascular congestion, full clear space opacity, flow effusion or pneumothorax, and no bony abnormality, normal chest. But what I think was really interesting is just watching those lungs move now. It seems like this person's getting caught on their breath, right? Like it's not completely contracting or where it should be. It seems like there's hyperexpansion of those lungs, and there's flattening of the diaphragms later on in the breathing cycle. And just to convince you, we're going to remap those diaphragms. It's not as smooth as the prior image that we had shown before, those graphical representations of the diaphragm moving in sync that are not, it feels like more rigid in this diagram, and it's being shown in that graph. And also just to compare to a normal patient breathing. Right, now that you've seen someone breathing, it's almost like seeing a normal person huffing and puffing after a marathon. That person breathing is very obviously not at baseline with their normal breathing cycle. So this person you can see as a normal patient breathing normally, and then on the left you can see that really constricted movement of those lungs. So one of those current investigations at Sinai is in how to interpret those dynamic digital radiographs. There really isn't a good standard way of interpreting what we're seeing. There's so much more information on that DDR exam. So again, you'd have to change the technique. You'd have to say there's with dynamic views during regular forced inspiratory and expiratory respiration. You'd have to put down the radiation exposure, which we will be measuring as part of our research, and the findings. Is there normal motion of the cardiomediastinal silhouette? Is there air trapping? Is there synchronous motion of the diaphragms? Are there other areas like fibrosis, like areas of bullous disease that would look different now? And is it regional? I think that's something I'm not mentioning here on this report, but highlighting back, again, the global disease of lungs versus regional disease of lungs. I'm sure a lot of chest radiologists in the room can tell you there's upper lobe predominant disease, lower lobe predominant disease, and things that you can probably see functionally different that really pulmonologists were not able to describe before, other than auscultation to the back of the lungs. And that's really different and a new way of looking at disease, I think, that I'm very excited by. So now we're going to pause a little bit and go into that pulmonary function test that I alluded to. So COPD, this is just it affects 16 million people, 56% of women, and it's the fourth leading cause of death behind heart disease, cancer, and accidents. And to monitor COPD and treat it, people have to do these very complicated pulmonary function tests at least 3 times. So this is a really long and strenuous exam. If you have difficulty moving and difficulty breathing, you have to follow the instructions of the tech, and you have to go in these different tools and machines to measure your lung function. And in the end, It gives you, 70% FEV1, which really, again, tells you global lung function. It doesn't tell you that one part of your lung is very healthy and another part is not as healthy. And it takes 1 hour to complete, so 3 different times you're gonna have to go for an hour and do this exam. And so, and it comes, and I'm showing this very little on purpose just because it is a very complicated graph to analyze, and I'm not a pulmonologist, so I'm not going to do that too much, but I just wanted to highlight how complicated that result will be. But here's a graph to show you the patterns that they're looking for to diagnose obstructive, restrictive, or mixed lung disease. And that makes a difference because if you have COPD obstructive defects, they do treat you based on that number that you get from that PFT result. So this is a direct area that DDR can affect patient care with. So if you're able to diagnose somebody's COPD and give them an FEV1 value, perhaps not even in an outpatient setting, but even in the ED setting when people have said obviously don't do it, the spirometry value is not as good in the acute setting, maybe it's time to revisit that because there's opportunity here to look at the radiograph and the PFT values. And here's how they treat it in the outpatient setting. You get specific treatments based on the group that you fall into, based on your result. So another current investigation that we're doing at Mount Sinai is to calculate pulmonary function. And I'm just going to give you a preview of what I will be presenting at Society for Thoracic Radiology, but it's really using that post-processing step, taking those measurements of the lung movement, the diaphragms, getting the areas of the lung, estimating the total lung capacity and the functional residual capacity, and being able to estimate someone's pulmonary function. And a huge value in this is that in this paper that you can see from a different researcher, you can see which areas of the lung are emphysematous, which I think is very fascinating, right? The air trapping that you can see in the blue regions and the yellow regions, in the inspiratory and expiratory phases. So blue would be the expiratory phase and yellow would be the inspiratory phase. And you can see how the lungs have changed in those areas. And that's really huge. The next thing obviously is diaphragmatic function. Again, this is another aspect of the kind of reevaluating the sniff test and seeing whether or not diaphragmatic motion, for example, with neurological disorders, seeing if that might impact diagnosis. All right, so now we've kind of gone over dynamic digital radiography with both functional information, anatomical information, combined as maybe a first-line test, and a lot of interesting applications. So are there other areas that dynamic digital radiography can impact? A little bit of a spoiler alert. So one thing is in pulmonary nodule detection. If you can see the lungs moving, maybe that overlapping nodule that you couldn't quite tell if it was part of the lung parenchyma or not, it would be highlighted, I think, just based to the naked eye when you're evaluating the patient. But also, you can get temporal subtraction images and have that highlighted and analyzed in the post-processing step, maybe with AI applications, but of course that's not the current research direction they're going in, but someone should research that. And then cardiac function, if you can measure the areas of the lungs, why not do that with the heart? And there is some research in that direction also. You could see the beating of that heart right earlier, and you can, based on the change, the white and black pixels on the digital radiograph, you can kind of estimate the perfusion and the ejection fraction of that heart as it's pumping. And they were able to correlate that with the ejection fraction that they obtained with DDR, and it was actually a very good R. You can see over here, it's kind of unbelievable, but I hope that there's larger studies that are able to correlate that R value of 0.93 and 0.96. All right, and yes, I'm aware other technologies are also on the horizon. So there's the bedside portable ultrasound for your smartphone that emergency physicians can use at the bedside to diagnose ejection fraction. So I'm not saying that DDR is the only thing you can use, but it's fascinating to me that one image, what you would usually get anyway, a chest radiograph, can give you all of this information. You can get your PFT, you can get an ejection fraction maybe, you can get disease of the lungs. All right, so future applications. So current and future areas and applications. One is, another area that's very fascinating is ventilation and perfusion evaluation. So I will say that this is an animal model that they tested dynamic digital radiography with. In the first, on A, and this is in a porcine model. In A, you will see a completely normal pulmonary artery tree and kind of the perfusion of that underneath in the white and red diagram. And then in B and C, they induced left-sided pulmonary embolisms, right? So they've blockage of the left pulmonary artery, and in theory, you would have decreased perfusion, so there should be less red on that side. And I would argue that you can actually tell the difference. You can see that there is a perfusion defect on that side. So this is in animals, not in humans, but it's very exciting to see the potential of, again, another reason you can apply DDR in the acute setting is maybe potentially diagnosing PE off the bat, and maybe kind of avoiding the artistic form of a VQ scan, which is the Rorschach test. So anyway, and here is a diagram of, it's not perfected yet, but this is a preview of what you can do. You can, on the left you can see the ventilation of the lungs, highlighted in blue. As the lungs expanding, the blue increases. On the right is, in red, is the blood flow as it's moving through the heart. And again, this is just a show capabilities. It's not perfected quite yet, but it's a possibility. All right, another emerging area of investigation that is being investigated somewhat at Mount Sinai West, and now I think at Emory Institution, is musculoskeletal evaluation. And again, not just fractures that your orthopedic colleagues might be interested in, or your ED doctors, but what about the instability of the wrist that you were hypothesizing before? What if you could see the dynamic motion of that hand? Now, obviously, if you've got someone who's acutely fractured, they're probably not happy with you moving their hand like that. But if you were planning on, but if you were very not sure, especially with a pediatric patient, this is something that you could do. And going into pediatrics, this is the image gently is a huge movement in pediatric imaging. And as we had alluded to at the beginning of the presentation, there's a lot lower dose with flat panel detectors and digital radiography. And for dynamic digital radiography, think of diseases like cystic fibrosis that require young patients to be imaged routinely and repeatedly to measure the extent of their disease. I know they get a lot of repeat CTs throughout the course of their treatment. And the question is, what if we could, instead use radiographs and evaluate their lung function and their anatomy at the same time in a low dose manner and track them that way. Again, not doing that research now, but that's an area to be interested in. And also therapeutic monitoring, kind of touching in that same vein. Response to asthmatic treatments. If you're using bronchodilators, you can visualize that and see if somebody's getting better with asthma or COPD or whatever disease you're tracking with treatments. And then also perhaps pulmonary toxicity, cardiac toxicity with drug trials. I know it's not, there's been some articles on how to monitor people in chemotherapy trials or other new medications, but perhaps you could use dynamic digital radiography as a way of monitoring those patients. But again, that would have to be another area of research that's not currently available. So the limitations of dynamic digital radiography are that it's very new. It's not integrated into the radiologic or clinical workflow yet. So there needs to be more familiarity for ordering providers. There needs to be more research and cross-discipline presentations and publications for awareness. There needs to be standardization of that technique. I didn't touch upon this too much, but part of that sequential imaging that I discussed at the beginning, that protocol can be changed, right? The forced expiratory volume over 1 second, that needs to be implemented in a very specific way, perhaps, to diagnose pulmonary function. Or maybe it doesn't. That used to be based on spirometry, so 1 second, right, to force out your, but if you could see the lungs breathing, would that be different from a normal tidal breath? And maybe you need a different kind of technique for ejection fraction, so on and so forth. You also need to maybe develop portable units so that it can be rolled out in the ED setting. Again, I may have alluded to this in the beginning, but you have someone standing getting an AP radiograph in a very standard technique for regular radiographs, but a lot of radiography is also done in a portable manner, and a lot of the emergency applications I discussed would be much better with a portable unit. Next is the post-processing steps. Those need to be, again, researched and analyzed. Which ways can we enhance DDR to get the best images, and which ways can we get the best diagnoses? The next is direct integration with PACS, which we've recently achieved, but which images would be most useful for radiologists or even pulmonologists, kind of sending back and forth. And lastly, the financial cost of the technology to the organizations and patients. Right now it is FDA approved, kind of as a cine loop for radiography. So just to emphasize that more research and innovation is necessary in dynamic digital radiography and in radiography in general. And to reemphasize that all that we've discussed today is that it's functional information and anatomic information in a first-line test. And I know that was a whirlwind, and I talk fast. I think people were supposed to slow me down. Sorry. So if you have any questions, feel free to ask me, but that was, I know, very shortened talk just based on my speed. Oh, yes.
What is the radiation dose? Is there any radiation dose different from DR, EDR? What is the difference between the radiation dose?
That's a great question. So the question was that what's the difference between digital radiography dose and dynamic digital radiography dose? So one thing, so we actually just got a lot of information recently on that. And so a normal chest radiograph, if you were to get it, is about, I want to say 0.1 to 0.2 milligrays. And so dynamic digital radiography, depending on the sequences and things, so far we're averaging, I think, 0.3 to 0.4 because you're getting a lot of sequences at once. But because we don't have a large sample size, I want to say we've only done about 50-ish patients, and we're working on doing more, that we want to make sure that average is, again, done over a larger population. Okay, great. Thank you so much.